On episode 615 of the 40 Plus Fitness Podcast, we meet Dr. Alan Reznik and discuss his book, The Knee and Shoulder Handbook. You can find the full show notes for this episode at 40plusfitnesspodcast.com/615. Have you decided you're ready to make a change? To reclaim your health and fitness? The 40 Plus Fitness Podcast is here for you. Each week, we dive deep into health and fitness topics that affect those of us over 40. I'm Coach Alan. I'm an NASM certified personal trainer with specializations in corrective exercise, behavior change, performance enhancement, and fitness nutrition. A Precision Nutrition Level 1 coach, a FAI certified functional age-link specialist, and an OTA Level 2 online trainer. Each week, I'm joined by our co-host, Coach Rachel. She is an NASM certified personal trainer and a RRCA Level 1 run coach. Let us be your coaches as you find your way on your health and fitness journey. All right, let's go. It's that time of year again. We drift in with the pumpkin, frappa, whatevers, hit the Halloween candy hard. Then comes Thanksgiving, the Christmas parties and feasts, roll into New Year's, and we're completely off track on our health and fitness goals. It's so frustrating to watch the ground we covered during the year get completely washed away by a few indulgences during the holidays. But don't give in and don't give up. Join me for the Crush the Holidays Challenge at 40plusfitness.com/crush. This 35-day challenge runs from November 20th through December 24th. You'll have the accountability, support, and guidance you need to stay on plan and not lose ground like you may have in the past. You'll get daily support from me and be surrounded by like-minded people in our private Facebook group. There will be plenty of fun challenges and games to get and keep you moving forward on your health and fitness goals. Don't let the holidays derail you. Crush the holidays with the Crush the Holidays Challenge at 40plusfitness.com/crush. 40plusfitness.com/crush. Hey, Raz, how are you?
Good. How are you today, Alan?
I'm doing good. We're starting to get into the fall, which means that the weather's just the same as it was in the summer.
Oh, my goodness. Oh, that's so funny, Alan.
Yeah.
Yeah, we get like 30, 40 degree fluctuations up here. I think we're back up in the 60s and we're about to shoot right back down to the 30s. So, yep. I know, it's like a roller coaster. And then it'll be winter.
Yeah, it'll be winter.
Mm-hmm.
Well,
my goodness. That sounds lovely, though.
But I guess some people have to live up there.
Yeah.
We can't all live in Panama. It's a small country.
No, that's right.
All right.
Oh,
well,
goodness.
Are you ready to talk about knees and shoulders?
Sure.
All right, let's go do this. Our guest today is a board-certified orthopedic surgeon specializing in arthroscopic surgery and sports medicine. For more than 2 decades, he has been awarded the title of Top Doc in Connecticut Magazine and recognized as one of America's top physicians by the Consumers Research Council of America. He has served as team physician for the U.S. Tennis Open and the New Haven Knights professional hockey team. He's widely published with over 60 journal articles. He's also the author of I've Fallen and I Can't Get Up, a guide to fall risk and prevention. He holds a number of orthopedic patents, and his personal mission is to help patients and readers better understand their health and share the knowledge and tools to actively participate in healing their problem joints and achieve the best results possible. With no further ado, here's Dr. Alan Reznik. Dr. Reznik, welcome to 40 Plus Fitness.
Thanks for having me.
You know, I've always been generally fascinated with the knee and the shoulder, and it's because, growing up as an athlete, I saw a lot of it. You mess up your shoulder, you mess up your knee, you mess up, but those were the big ones. If someone's going to be out of a sport, it's a dislocated shoulder, it's a torn meniscus or torn ACL. All these things are happening around us when we're playing sports, and then it comes back around 25 years later when you're in your late 40s and 50s, where such and such has got a bad knee, or they like I did, tear a rotator cuff. So this was kind of a fascinating book. And what I like what you did, and it was actually brilliant, and I want to do more of that today, is you talked about how someone will come in and you'll start talking about a procedure that they need, and they kind of get that glazed over look in their eyes, and you're the Charlie Brown teacher going wah 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 wah,
Yeah.
and they're not
Yeah,
picking
I love
up
that analogy. It's so true.
they're not picking up a bit of what you're saying. So the book and what you did before, but this book now is a tool that we can have to basically say, when we're talking to our doctor about a particular thing, I can go to this and at least have a better understanding, because sitting in their office after they first tell you, I'm gonna grab this here and stitch that to that and anchor that there and do this. It is hard. It is hard. I was fortunately I was a personal trainer, and kind of understood some of the anatomy stuff. So when I was talking to my orthopedic surgeon, I was geeking out on it, but I know that's not what you get on a day-to-day basis, and it's not what most people that are listening to this podcast, they're going to hear something and it's going to shock them, and then for them to basically be able to absorb, okay, what exactly is this? What's the recovery time, and what does this mean to me? I think you put that together in a very non-wah wah way.
Yeah, thank you. Thank you for saying that. Yeah, the book is just to keep, give you a background a little bit. What I found was people were having a hard time understanding the complicated ideas, and most people could hear the simple ideas, but if I asked them to say it back, they couldn't repeat it back. So I started to write little booklets for my patients on each diagnosis. It started years ago. And every year I would work on them. And then if I would have a new employee, I would say, okay, let's have the new employee read them again and say, listen, do you understand this? And they pick up and go, Dr. Reznik, this whole page is gobbledygook. You have to fix it. And
that's hard as a new employee. You're trying to tell your boss, hey boss, this sucks.
No,
but
I actually invited. It's a funny thing, in the operating room, and we had this happen in the academy because I was on the patient safety committee years ago. And I know we're going to go off a little bit of a tiny tangent for a half a second. But, they asked a bunch of people on this committee, how many people in the room could raise their hand and say that the people in the room will tell you when something's going awry and be able to help you. And I raised my hand immediately and I went, absolutely, because I try to keep the environment in the OR like the environment in the office. Like, there's no such thing as a stupid question. There's no such thing as something that you think I should know that maybe I do know, maybe I don't know, but if you say it, I'm not going to get mad. So to have that sense of the environment around you, that when things are going awry in the OR, you want everyone to be cool, calm, and collective, and you want all the people to add their experience to save the day. And I did level 1 trauma for many years, and you have people bleeding to death, and the shit would hit the fan, and it would be horrible. It'd be like MASH. It really was like that. And if everyone in the room wasn't focused and everyone was afraid you're going to get mad if they made a good suggestion, that would be a problem. I have a funny rule, like if the nurse hands you something but you didn't ask for it, try to figure out why she wants you to use it.
Yeah.
Because when you're in trouble, sometimes you need everyone rowing in the same direction. So I see that in the office as well. I want my patients to be rowing in the same direction I am, and to get them to row in the same direction, I find that they often lack the basic understanding of the problem to understand why I want them to do something. And when that happens, they're less likely to follow the instructions.
Yeah.
So by creating these booklets and little handouts and little things I've done and little funny sayings that I tell the patients along the way, it's just my effort to try to get them to be on the same team with me as I try to help them, because then it goes much easier. And as like to your point, you said, people come in, they have these ideas, they think they want this, they think they want that. So many people have a story they want to tell you about some other horrific thing that happened to someone they know or that happened to them.
Yeah.
And one of my wisest teachers when I was in medical school said to me, it's a fair question to ask a patient, why are you asking that? And you're often surprised by what they say. And they'll say something like, oh, my Uncle Benny had that problem and his shoulder hurt the same way mine did. And by the time they finished with him, he couldn't do anything anymore. And then you start to feel through the whole situation. Yeah, Uncle Benny really had something else. Uncle Benny had a sarcoma, or something.
Yeah.
And they're scared to death because Uncle Benny had a tumor. And all they want you to tell them is they don't have a tumor. They could care less that they can't pitch anymore. So it's often a surprise that, sometimes we place assumptions on patients about what they really want. But unless you take a minute or two to listen to them, you don't always know what they're asking. And so sometimes, like I said, it's a fair question to say, why are you asking that? And then they tell you. And then when they tell you, sometimes have a good sense of the answer that they're looking for, at least to help them along. And then hopefully figure out their real problem with their shoulder and then get them to the next step. So that is a hard thing to do in the office.
Yeah. And so in trying to get a patient to row the same way, which I love that analogy, because I think a lot of us, of course, we've got Dr. Google, which makes us uberly intelligent.
Yes. Gives you googly eyes too.
Yes. But we want the shot, we want the pill, we want the script, we want we go in there kind of with some expectations, and it's not always the patient's fault. I think the medical establishment in some cases has kind of set the same criteria. I'm going to give you 7 minutes, tell me what you want. And so the patient comes in and says, well, I know my uncle got this cortisone shot in his knee and he said he felt great. I want a cortisone shot because I'm in pain.
Right.
Can we talk about what that injection's about?
So there's like, I can unpeel this in a couple of different ways, but I'll try to stick to the basic ideas, right? So cortisone is a fantastic anti-inflammatory and extremely good locally acting. So if the primary problem for your pain is inflammation from something, it could be anything. It could be a torn cartilage, it could be torn meniscus, it could be instability, it could be a kneecap that's dislocating, or it could be a host of other things like Lyme disease and rheumatoid arthritis, and you can go on and on and on. I know we don't have that giant time to discuss. That could be another show.
It's all in the book, but it is all in the book.
It is in the book. But at the end of the day, you have to dissect out, what am I treating and why am I treating it? So going back to two pieces of that, again, some patients, they have a tournament this weekend and you're treating them because they want to give a shot so they can play better this weekend because they know their knee is painful and they want to have the weekend to do it. And when I was a young physician, I'd get some guy who's 70 or 80 years old wearing 2 braces and limping and come in and say, Doc, you got to give me a shot. And I'd say to them, you're crazy. Why are you still playing tennis? You're going to hurt yourself. And then as I got older, I started to have a better appreciation for the aches and pains of life.
Yeah.
And now, I have a patient who's 80 years old, who's got his arm taped up and his elbow taped and 2 braces on, and, they hurt themselves and they have a tournament this weekend. And I'm almost like, where do you want the shot this week? Which is not, I wouldn't say that's the generally right answer, but if it is the right answer for them for their acute inflammation and it is the best choice at the moment, I am happy to give it to them to restore their quality of life. So if we're giving the shot because there isn't a lot of choices, the patient isn't going to go for a surgical option, they know it's going to last 6 months at best to a year, and we know that the end game might be a knee replacement at some point, then it's not unreasonable to do it a couple of times. I have a hard rule. I don't like to do it more than twice a year. If you're doing it 3 times a year, then I don't know what's wrong with you. I'm not really treating the problem. So that's a rule of thumb for me. The other rule of thumb is I never say yes to someone who just says, hey, doc, just give me the shot. I say, no, tell me what's wrong. Let me examine you. Let's get an x-ray. Let's make sure it isn't Uncle Benny's tumor first, because I'm not getting an injection into a tumor. And let's do all the things we have to medically to kind of piece together what's really wrong. And then I can counsel you whether the shot is a right idea for you. I think you're into this a little bit, and I'll take a little sidestep onto glucosamine and chondroitin, because that's something people ask about all the time. Various supplements. And I have a little rule of thumb. I was actually talking to a well-known sports person years ago, who's at Harvard, and she's a delight. She's fantastic. And she said something very clever to me, and it stuck with me, and I think she's right, in that she said, if you use these things and you do it for a month and then stop for a week and you're looking for the bottle, there's a good chance it's helping you. If you stop for a week and you don't miss it and you're not looking for the bottle, there's a good chance it made no difference. So some people are on glucosamine or food supplements for years and years. And if you ask them the question, do you know if it's helping you? And they don't know. They have no idea. And I said, how about stopping for a week and see if you're looking for the bottle? And a lot of people have stopped for a week, doc, I don't feel any different. I wasn't even looking for the bottle. Okay, it's not working for you. And there are some studies that show that glucosamine in some settings in Europe, there was a big study of 600 patients that showed it's just as good as Celebrex as in helping people feel better for bad knees and some bad joint issues. And then we do give it to our dogs and horses with some success. So I do think there are people who are responders, if you will, who will take glucosamine and have fantastic result. And I think there are plenty of people who are non-responders. So the acid test of taking it for a month and then stopping and seeing how you're doing without doing other interventions. Obviously, if you do 6 things at once, you never know, right? I give someone a shot of cortisone, then they take the glucosamine. They said the glucosamine worked, and you go, you're taking the anti-inflammatory and I gave you a shot. Not sure the glucosamine was the number one thing.
Well, they got that for $30 at Costco. So, that was
right. A little bit less than the copay, maybe, So if you do it in isolation, you can piece out whether or not it's working for you. But I tell people to listen, if you know it's not making a difference, don't continue. There's no reason to do that. And there's some caution in diabetics. They don't really want them taking glucosamine because it has some sugars in it. And diabetics could be taking a lot of glucosamine, not realize it could be throwing their sugars off. So there's some cautions there. So nothing is as straightforward as people like to think. A lot of food supplements have other issues, and then you have to be a little careful.
Now, collagen's one that's been very interesting to me. If I take it, basically my fingernails and I would say hair grow, but it's not the hair that you would be looking at right now. But my fingernails grow like crazy. Yeah. And it's odd because to me, collagen is basically 3 amino acids. But you get those amino acids from other whole foods.
Sure.
So is collagen really something that's necessary if you're already eating a decent amount of protein, or what's there?
Yeah, I always think about chicken soup, because traditional chicken soup, you boil the bones and everything in the pot, and the collagen and all the different parts get boiled and digested and into the soup. And chicken soup is so good for you, right? As they always say. So I do think, and this is very hard. Nutrition is a tricky subject because the natural tendency is to look at the RDA, right? The minimum daily requirements. And the minimum daily requirements isn't the optimal amount for health. And people get confused about, well, I took the minimum amount of this, I should be fine. Well, we don't know, number one, if you're absorbing it completely. And number two, we don't know if that's really the ideal amount. We just know it's the minimum amount. And then saying, oh, I just took 5 times the minimum, that's good. Well, we don't know that either. That might be equally bad. We just don't know.
Yeah.
So it's tricky. I think people do have focal deficits in things that they don't appreciate. It's hard to get collagen in a very sterile diet. If you're eating pasta with cheese and you're using tomato sauce, there's really little collagen in that, right? If you're trying to avoid the red meats and the fat and the sinew of those things, you're not getting that kind of stuff either. But that might be a healthier diet for your heart. So it is a little tricky to know in each individual what they're getting, what they need. There are, and this is a well-known misconceived notion, there are plenty of people overweight that are malnourished. Yeah. Being overweight does not mean you're well-nourished. And conversely, the risks of surgery when you're overweight are equally as bad if you're grossly underweight too. So you have people with BMI under 18 or 18 and under have the same risk of complications of surgery of people with BMIs over 30 and 40. And that's also poorly understood. But I think the people with BMIs 18 are generally pretty malnourished. They don't know it. They don't make protein every day. So, I do encourage my patients post-op, if they have a fracture, to take calcium, vitamin D, and vitamin C, because those are 3 minimal requirements. And plus, try to eat a good diet with extra protein in it. So, I don't know if I really answered that question completely, but I think
you did. It helped. It helped. Because again, and I think maybe this is another one of those things. You try it for a month, then you go off of it, and you kind of see if that changes things. It's an experiment. N equals 1, and we all are bio individuals. So for some person it might work, and the next person maybe not so much so, but.
Yeah, I think the bio-individual idea, that's a great way of saying it. There's a big push in AI. I just went to a conference last week, and I don't want to get into this topic completely, but just quickly mention it. But we talk a lot about personalized medicine, knowing your genome ultimately, and then trying to figure out what you really need based on your genes more than anything else. And that's a huge project. We're not there yet, but the holy grail of it is I'm going to take a swab from your cheek, put it through a DNA analyzer, and tell you when you're going to get hypertension and which medication is best for you, or what your weight range should be to avoid getting hypertension, even better, or you're someone who really doesn't absorb vitamin D very well and you need extra D in your diet. And all that is possible in the future. It's going to come. It may take 20 years, but it's going to come as the techniques get better and better. So individual medicine, we're all individuals. We all do things internally slightly differently, yet we're all the same. It's amazing how we all have 5 fingers and 5 toes and a nose and 2 ears and 2 eyes. That's amazing. But at the same time, there are little tiny things that are different enough that we can't say that any one medication is perfect for all individuals.
Yeah.
And conversely, the opposite, right?
And that's what's kind of striking about all this is, they spent $3 billion to basically tie down a genome, a human genome. And now with AI, in a matter of a fraction of the time, they're going to be able to tell you so much more about yourself. It is kind of fascinating, that technology, the way it's taking off. So I am looking forward to that. Now, another crutch, if you will, is the knee brace. I see a lot of folks will sit there and they initially, maybe there's an injury or something acute, or maybe there's not, but they put a knee brace on and they feel more stable. They feel more in control. Their knee doesn't hurt as much. And so as a result, now every time they come to the gym, they're wearing the same knee brace. And, of course, I'm a personal trainer, and I look at the human body and I say, well, if you don't put the human body under some stress, it will get weaker, not stronger. And so you do have to find that appropriate hormetic effect stress so things can improve. But is that the case with knee braces? Is that just something we should
you're asking
self-medicate?
such a fantastic question, because there's, again, like a lot of the questions, and again, with my patients, there are so many layers of answers, right? So you kind of start with the gross answer, like, is your knee really unstable, right? So you can check the ligaments. You can say, oh, the MCL, the ACL, the LCL, the posterior cruciate ligament, they're all working perfectly. So is the brace creating stability vis-a-vis the ligaments? And the answer would be no, right? Is the kneecap coming out of place? Well, if the kneecap is coming out of place, there are braces that help keep the kneecap in. Well, that would be an answer for a specific question. Again, very personalized, getting back to personalized medicine.
Yeah.
Other people have issues that, they have a little tiny bit of arthritis, maybe they have an inflammatory process, their knee is sore all the time, a little bit, and they get stiff after the soreness. But if they put a compressive brace on of some type that's neoprene foam, it makes the knee warmer. And just like hot yoga, if the knee is slightly warmer, even a degree or 2 warmer, it'll be a little more flexible. It'll feel a little better. So some people, it's a thermal effect. You have some kind of brace that keeps the knee warmer and they feel better. Other people, it's a mechanical issue. And there's a third group of people, which and aside from the injuries, we can talk about injuries another separate, but third group of people where the brace itself serves as a funny reminder, almost like tying that ribbon around your finger, right? So if they know that they get into certain ranges and they have knee pain because their kneecap is worn on the superior pole, the inferior pole, or the lateral edge of the kneecap is worn or whatever, and there's a certain range that gets them in trouble, and they put that brace on that inhibits them slightly, they don't get into trouble, right? So that would be another way of using the brace to stop that motion that gets into trouble, or remind them not to go there. And then that may be a benefit in and of itself, because then they can exercise and feel comfortable exercise, but they're not going to go to a place that's going to hurt them. And the last little piece of that is proprioception. And I'm sure you're familiar with the concept where, you can close your eyes and touch your nose, just do that. And you know where your nose is, you know where your finger is very well. You know where your knee is pretty well. But sometimes as we get a little older, maybe your reaction time's a little slower. Maybe your ability to really tell where your knee is. Maybe you're losing proprioception because you have a little spinal cord issue. And there's a herniated disc that gives you a little trouble. And you don't really realize it's affecting proprioception more than anything. And you put the braces on and you feel your knees moving and you have a better sense of where they are in space, and you feel more comfortable doing whatever you're going to do because you know better where your knees are. That's a very complicated idea for a lot of people, but the GPS thing kind of brings it home. Like, I close my eyes, I know where my knees are. Now, if you tear your ACL has stretch fibers in it. Some people lose the proprioception in their knee when they tear their ACL, and they feel gorky and uneven, even when you reconstruct it. And we talk about that after reconstruction, for another year, people have apprehension when they play. And there's actually a re-injury rate of that knee and the contralateral knee, the other knee, when you don't know where your knee is in space and you make a funny move. And there's some data saying now, like, if I brace you, even though you don't need it, and your ACL is good, and the stability is good, and the reconstruction went well, and your meniscus is healed, and I use a brace for that next year, return to sport, it's not really protecting the ACL so much. It's giving me that little extra confidence and a little better proprioception, so I don't hurt the other knee or re-hurt this one. And for some people, that is golden. That makes all the difference in the world. They're not as tentative. I have so many stories of people cut to the right, cut to the right, cut to the right, have a right ACL. Next year, they come back, they go to full out sports, and a year later, they come back with the left one, the same exact injury, doing the same maneuver the other direction,
Yeah.
So there is some value in that little bit of extra security that the brace might give you, even though scientifically it doesn't really react fast enough to really protect the knee in the way you think it might, but it may have other benefits we really can't measure.
But I would still recommend, before you just start throwing on a brace, have a conversation with a physical therapist, have a conversation with a orthopedic surgeon.
Yeah, find out why you might need it, right? And if it's a good idea or not. And again, I think there is that idea that the brace is sort of a semi-crutch, and that you don't strengthen as well because you're using the brace, and somehow that's going to weaken your leg. But I think that's the chicken and egg problem, right? There's something wrong with the knee, and you're not firing your quads fully anyway because your knee hurts a little bit. Put the brace on, you feel a little better. Doesn't mean the problem that makes you not fire your quads and make your quads stronger goes away.
Yeah. Well,
right?
I totally agree. I totally agree with that. I see people wearing braces, and I don't mean for just a few weeks or a few months. I mean, every single day for years. Just they come into the gym, they're wearing a brace, and I'm like, okay, if I heard that long, I'd be talking to a doctor or a physical therapist. I wouldn't self-medicate effectively that long.
I think if you're wearing a brace for a year and you don't know what's what and why it is, and you find that you absolutely need it and you can't do anything without it, then you should get evaluated and find out that there isn't something simple that they can be done that will make you brace independent more quickly. That makes total sense to me.
Now, I had a boss, and he went in for a knee replacement. My best friend, one of my best friends went in for a knee replacement. He's in his recovery period now. And the science, I guess the kind of knowing how all this works, it's where I would say most orthopedic surgeons kind of become carpenters, if you will. So it's kind of fascinating to me to understand it. We could take basically a partial or full artificial joint and replace the joint, and it'll function fine as long as the materials hold out. Can we talk a little bit about knee replacement, when it's the right thing to do, and considerations as we get into it?
Yeah, and like everything we do, whenever we do any kind of intervention like that, and knee replacement is a big intervention, right? We're removing the ligaments, we're opening the kneecap up, we're taking the surfaces off, we're putting a metal and plastic surface on. It's a bigger surgery than an arthroscopy, right? Like repairing the meniscus, much bigger surgery than that. And technically demanding. It has to be done right. I have people say to me, well, I really want that particular knee and I want this guy to do it. And it turns out that guy does a different knee. And my answer to that, and I hear people say this all the time, probably a lot of listeners are thinking, I'm going to find the best replacement. I'm going to have the best guy do the best one. I figure out what it is. And the answer, that's the wrong answer, because you really want the guy to do.
I gotta tell you this story you just brought up. Okay, when you say the right knee, this is not the right or the left knee.
Right. It's the correct one.
The correct one. The right type of replacement knee.
Placement, yes.
Yeah, this is so funny because my wife went in and she was getting cortisone shots in both of her knees, and the doctor was a great doctor. And this was a Cleveland clinic down here in Panama. And what he did was he said, okay, well, he's going to give it a shot. He went to give it a shot, and then in the right knee, and the shot itself was quite painful. So she's squeezing my hand, and she's he says, okay. He says, I'm a left knee expert, so this next one won't hurt nearly as much.
Oh, I love that. That's great. Yeah.
And he was right. He was absolutely right. She took the left knee and said, you're absolutely right. You're a left knee specialist. It wasn't until we left the office that I explained to her that was a joke. But
Bravo. You're right. It was a joke. Yeah. We there's all these silly jokes that go along with that, which are terrible. Like, why the lady cut the left side of her body off?
I do not.
Because she's always right.
Yeah.
Right.
Okay. Well, so we're talking about the right type of replacement joint for the right type of surgeon, for the surgeon that's specialized in that particular thing.
People read all these things. I want this joint. I want the custom one. I want the one where they do the MRI and they make it exactly to my body. At the end of the day, you want the one that the surgeon is using is most comfortable with, because each one, no matter who makes it, no matter what the materials are, no matter who the manufacturer is, every single one of those knees have nuances that are unique to those knees. Every single individual has nuances. And you want the person who's done, thousands of knees with this prosthesis, so he knows every trick in the book to get that thing in perfectly. To give him the challenge of giving a knee set and equipment that he's not used to is putting him in a disadvantage, and then ultimately you're at a disadvantage. So the materials are so good, the techniques are so good, the things that are good and bad about the total knees are so well known that by and large there are subtle differences in the different knees that are being made, but most of them are really fantastic, and if you get the differences are small enough that the technical part of it is much more important, ultimately, because you can have the custom made one where they do the CT scan, MRI, and the bones aren't registered with the computer perfectly, and the thing goes in perfectly wrong by a few millimeters, and that's enough to make it not great, or less suboptimal. So if the guy who's doing it doesn't get it in exactly the way it's supposed to be, then all bets are off, and you want to give him all the tools he needs to do it the most comfortable way he can to make sure that it goes in perfectly for you. So my rule of thumb for that is, if you pick a surgeon and you like him and you met him and you think he's a great guy and you think he's got the chops and he's got recommendations out the wazoo and you've seen other people with good results, let him do the one he wants to do for you, because he's going to pick the one that's best for you, because why would he pick anything else, right? It doesn't make any sense not to pick the one that's going to be best for you. Someone said to me once, well, would you do this for your mother? And I asked, well, do you know if I like my mother? First of all, you never asked that question. But I have to love my mother. She's fantastic. She's 86 years old, still works full time. She's the most amazing person on earth. It's incredible. But I do make that little joke because, people ask that question. The reality is why would I ever do something I wouldn't do for a family member? I'm here with a skill set. I have some expertise. I may not be right all the time. I may make technical errors. I'm not perfect. I do the best I can for every one of my patients, but I'm not going to decide to do something that would be wrong, right? On the get-go. It just doesn't make sense to me. And if there's something that's a marginal call, I'll have that discussion with you. Look, this is a marginal call. You can go this way or that way. No one can tell you 100% the right answer. These are the pros and cons. We have to make this decision together. Shared decision-making is the common buzzword, right? But that's harder to do than just say, hey, you need this. I'm going to do it. You'll be fine. That's not really how it works. It's not really like that in the real world.
Yeah. So the way I look at it is you're the head coach of your own health. And then you have these assistant coaches, and one of your assistant coaches is your doctor, your surgeon. And your assistant coach is going to say, I think we should run this play. This is the best play, but alternatively, this is the next best play. Then you have to make the decision what's going to make the most sense for you. You don't just fire your offensive coordinator because they told you something you didn't like to hear. You listen to what they say. That does happen a lot.
Yeah, that does happen a lot. I get fired once in a blue moon because I tell someone the truth and they don't want to hear it. They want something. They have a fantasy about something that might work for them that I know won't. Yeah, and just like, look, I know you can do that, and just because it looks like a hammer, it's not a nail. I know you can do that. But to get back to the total knee question, so how do you decide? And this is always the sort of a spectrum of things. If you have young people, and 40 is still young, 40, 50 years old even, and even 60 nowadays we consider young. The older I get, the younger that seems, right? That cartilage preservation and preserving the knee and doing things to get the knee mechanically better can preserve the knee and buy time. And at the end of the day, if that will work very well and get rid of the majority of your pain and make you very functional and buy you 3, 5 years, 10 years of time, it's probably worth considering, because a total knee is not alive. I think I mentioned this in the little pre-discussion we had, that knee replacements are put in and they're metal parts, right? And there's a plastic liner. And just like tires in your car, they got a mileage on them. A certain number of miles, they go. That's it. So if you're Mario Andretti or one of the fast drivers on the road, in the race car drivers, the drag strip, everything like that, those tires got to be changed every 200 miles. If you drive like my grandmother, it's going to last you forever. but most people have very high expectations once they have the knee replaced. And if they drive it too hard, it's not going to last them. And revision surgery is more complicated, right? So, but the modern knee replacement you get with casual good use, not crazy use, probably 20, 25 years is very possible. So, if you're 65 and you get 20, 25 years, you're talking 80s and 90s, most people will be very happy with that. But if you're 45, you get 25 years, you're 65, you're looking at revision, maybe that's not so great. So there's a kind of a window in the middle where we try to do things to buy time. Some of those don't work. I mean, if we're asking biology to heal something and Mother Nature says, sorry, I'm not going to do it, I can stand on my head, repair the meniscus, sew it together, do all these things, and your body decides, I'm just not going to heal it. Or you don't follow the post-op instructions, either one of those two things. I can't help that, right? But if it works, it could be a home run. So, we're always deciding that. And then again, that's a personal decision with the patient. But someone comes into my office and their x-ray looks normal. I say, my knee hurts and I want my knee replaced. I'm going to examine their hip and their lower back because, referred pain is a problem. So some people go, my knee is killing me, my knee is killing me, my knee is killing me. And you try to rotate their hip and their hip doesn't move at all. And that's the most common thing that's missed. And they have advanced arthritis of their hip. You take an x-ray of their hip and the hip is shot. And the knee x-ray is perfectly normal. But the internal map of where the nerve pain fibers are is off. You can't see the inside of your knee, you can't see the inside of your hip, but it's the same bone, right? It's the femurs. The knee bone is connected to the hip bone. We know the song, right? It's really true. And when you see that, you need your hip replaced and your knee pain will go away. And people are in total disbelief. And I had one patient who broke his hip actually and was so convinced it was his knee. He was so adamant it was his knee. They never checked his hip in the emergency room. And he had a small fracture that was slightly displaced, but his hip was not useful. He couldn't walk at all. His wife and his daughter were nurses. They took him home, took care of him for 3 days. He came into my office on a stretcher, could not walk. I examined. The first thing I did is check his hip because his knee looked normal and took an x-ray and he had a fractured hip. We brought him back to the hospital, fixed his hip. His knee pain went away. To this day, he still doesn't believe me that it was his hip. Well,
you did put him under. You did put him under for the surgery, so he doesn't know what you did.
Right, exactly. But it's interesting. His map was so strong, I could not convince him otherwise, and it didn't matter what. And he convinced everyone in the emergency room it was his knee, and no fault of theirs. They really didn't understand, but they let him go unable to ambulate and didn't go the next level. So I think that people underestimate referred pain frequently. And they overestimate the uses of knee replacements in certain settings. So like if the knee looks normal and there's nothing on x-ray and you're not getting your knee replaced for knee pain, you got to figure out why your knee hurts. And there are other reasons. So I think that's also a caution to the wise.
Now, about 4 years ago, I had a client and it's the first time I'd ever heard of this in my entire life. And so I was just kind of lost when he first started telling me this, but he came up with a frozen shoulder. And so now I'm, unfortunately I'm looking on Dr. Google to try to figure, okay, what's going on with my client? And the reality was there was zero I could do for this particular client because that was way outside of my my scope of anything. And I wasn't able to help him. He did get some work done and was able to recover some mobility to his shoulder. But this is actually a lot more common than I thought it was. After reading your book, I was fascinated as I kind of went through that chapter because again, I thought, as I got into it, I'm like, well, I had a torn rotator cuff. That's probably what I'm going to want to talk about because it happens to almost all of us at some point. But I just feel like this is just something no one ever talks about, but it happens. And when it happens, it's quite devastating. So can you talk a little bit about frozen shoulder, what it is, and kind of the approaches that you're going to take to recover from it?
Yeah, frozen shoulder is interesting on the initial level is that your body has decided, in just in microscopic terms, that the lining needs to be tighter, if you will. For whatever reason, your body thinks that the fibroblasts that hold all the lining cells start to fire up and create scar tissue, and they start to do this. They start to shrink. And as they shrink, the ability to rotate the shoulder and the ability to move it starts to decrease. And the endpoints become painful. So what happens is you self-reduce your range because the endpoints are painful, and slowly, insidiously over time, which means, so slowly, it's like watching a pot boil. You don't really know what's happening until it boils over, right? This pot is boiling very slowly, and as it goes on and on, you get less and less range of motion. And so sometimes people show up, all of a sudden I got a frozen shoulder. No, really, it's been happening for 4 or 5 months. You've been progressively getting worse. Just today you realized you can't get your shirt on anymore because it's gotten so bad. Interestingly, women notice it quicker than men, because women notice when they can't do their bra strap, and men notice when they can't get their wallet out of their back pocket, which is a big difference in internal rotation, right? There's a lot more internal rotation required to get your bra off than to get into your back pocket.
I've never taken a bra off, so I can't.
Right. There you go. So anyway, having not doing it myself either. So, but I understand it because my patients tell me immediately that that's the first thing they complain about. Night pain is very common as well, but the functional range starts to decrease. Yeah. And so the frozen shoulder usually starts out, sometimes it's a minor injury of some type that inflames the cells, and then the body overreacts, and then it starts to freeze up on you. Now, some frozen shoulders have a natural course. Some people get a frozen shoulder, it gets inflamed, it freezes up, and then slowly over a 1 or 2 year period, it thaws out by itself. But most people can't wait that long, so we try to intervene. If you can get in the early stages, cortisone shot, anti-inflammatory, and stretching programs can slowly stretch it back out and bring it back out. In the really bad recalcitrant cases where people are just so limited, sometimes we end up manipulating them under anesthesia and removing the adhesions and getting them moving that way, and then doing aggressive therapy after that. The other side thing about frozen shoulder, which people underestimate, is that some diabetics are much more prone to getting it. Their fibroblasts don't behave as well. And there are a few patients in my practice where they've presented with a frozen shoulder and turned out had diabetes and didn't know it. So that's always a little caution, a doctor caution, a little red flag. Someone comes in with a frozen shoulder, doesn't seem like they did anything that would have caused it. You should think about the blood sugars a little bit. But the more common is 40 to 50 to 60-year-old females are more common, and diabetics is more common than non-diabetics.
Yeah, and that's what I thought was so fascinating about it, is that tie-in to diabetes. It's like, if you're diabetic, this isn't just another one of those reasons to try to start managing your nutrition and your blood sugars so you can address that. You're pre-diabetic or diabetic, start working on that, because this is just another complication that might be waiting for you down the line. I know from, with my client, he was just so depressed, if you will. I don't know if there was clinical depression, but he was just so upset that he had lost his arm, and he just felt helpless. And so I just say, if you notice your shoulder range of motion start, like you said, endpoint to endpoint, starting to get a little sore, check your A1C, talk to your doctor, and start addressing it from both sides.
Yeah, if that is a risk factor for you, for sure. some people don't really know, but they have the risk factors already, or they have a family history of it already. Those people should be more aware of it as a possible sign that there is that going on. It's not the chicken and egg that everyone thinks it might be, but it happens enough that it's worth thinking about it.
Yeah. Now, I love, and I said it 3 times on purpose, that you got in after this. We start talking about, okay, let's not have these problems in the first place by introducing balance. Can you talk a little bit about that and just some basic things we can do, the blocking and tackling, if you will, of life that we can do so that we're dealing with fewer of these complications as we get older?
Yeah, I think that what people underestimate, and the easiest thing to understand, if you've ever tried to throw a ball on ice, or imagine that, you're on a slippery surface and you're trying to catch yourself and your feet go out from under you. You have to recognize that the ground forces propel everything in your body. So if your feet touch the ground, the force from that area goes up through your entire body to your hands. So any sport, any throwing sport, any catching sport, any running sport, the ability to put force from the mid body down to the ground is key.
And I would say even beyond sport. I just stop you for a second. I'm sorry. Yeah. Picking up a grocery bag.
Yes, absolutely.
Just reaching down and picking up a grocery bag, reaching over to grab a cantaloupe off the shelf. Walking from washing dishes and turning and putting something into the dishwasher. Those are the same force couples that you're dealing with in sports, we're dealing with in everyday life. So this is not just an athlete thing. This is a living thing.
Yeah, if the dog's toy is in your way and you step on it, if you don't have balance, you're going to go down.
Yeah.
So the understanding of quads and hamstring strength to balance your knee, obviously, Achilles tendon and your foot and your toes and your ability to feel the ground. We talk about kids wearing shoes, the little, toddlers wearing shoes. And I always try to get parents to say, look, let the kid go as barefoot as they can, or with the socks with a little rubber on the bottom, and try to keep them out of shoes when they're young, because they need to feel the floor to get a sense of balance. If they don't feel the floor, they don't have the same sense of balance or control that if they feel the floor. Of course, you don't want your kid walking around glass on the ground, obviously they're safe environment, but in a safe environment, to have the shoes off on little kids, it's really great, because you're teaching them balance that's going to be good for later in life.
It's great for older people too. I'm barefoot right now, so just
it's great for everyone to feel the ground every once in a while. It's really good. So get back to what you said. I mean, absolutely true. If your hips are weak and you don't have, and I have plenty of patients come in who could do leg press at 250 pounds. I stand them on one leg and ask them to do a one-legged squat, and they fall over because they have the small muscles of their hip they have never exercised. The balance muscles of your torso and the balance, coordination of your arm movements and everything else, they've never really tested. They're in machines all the time, and they don't do any free weights, and they don't do any one-legged exercises or balance exercises. So balance is key for all of that. And there are so many good balance exercises to do. And yoga is one of those things that's everything about balance in yoga, right? So, I mean, that's a great thing to do if you have problems with balance and you can do it. I always do yoga on vacation because I get a hoot out of how little I can do and how much my daughter, who's a lot younger than me, can do. And she always looks at me and smiles when the instructor says, reach down and touch your ankles, and I'm at my knees still. I'm trying to go further because standing in the OR still all day, my hamstrings are very tight. So it's always a problem. But flexibility and balance is extremely important, and people reduce injury. So balance is everything in sport, and it's everything in daily life as well. Wet floor, wet surfaces, a carpet edge, kids' toys, crack in the sidewalk. How many times have people hit the crack in the sidewalk and fallen, and how many times, if they could hit the crack in the sidewalk and had good balance and not fallen, that alone would save a lot of injuries. So 100% right on that.
Dr. Reznik, I define wellness as being the healthiest, fittest, and happiest you can be. What are 3 strategies or tactics to get and stay well?
Well, I think the first one is we go back to balance, right? If you can work on balance every day a little bit, even a small amount, I think it's going to go a long way for all your activities of daily living and sports too. So I think that's very important. I think the second thing is really be aware of yourself, right? So like, as we talked about before, if you're using a knee brace every day in the gym for 2 years and the nagging ache doesn't go away, well, maybe you should get it checked. So, have a little self-awareness, check in with your body every once in a while, make sure that things feel right. And probably the last thing is nutrition, right? So, avoid the situations where you decide to be super thin and you're eating a fad diet, and then you rebound because you come off the fad diet, you go back to regular food, and your diet's not that great in the first place. So, if good nutrition, good balance, and self-awareness are probably the 3 top things that I would think about as a general health rule. There's so many other things we could talk about, getting the checkup, making sure your cardiogram's okay, like check the cholesterol, but those feed back to the self-awareness and the diet and balance and some, exercise, 20 minutes a day of walking. They talk about 4,000 steps, they talk about 10,000 steps, but if you're not doing something every day, even if it's 20 minutes of walking, it's good for brain health, it's good for your body, it's good for circulation, it's good for your heart. All those things are important.
Dr. Reznik, if someone wanted to learn more about you or the book, the Knee and Shoulder Handbook, where would you like for me to send them?
So I have my own website, drreznik.com, which is DRREZNIK. It's a little tricky on the spelling, but it's there. I'm also an orthopedic surgeon in Connecticut, so ct-ortho.com is the orthopedic group. Very simple web addresses. The book is on Amazon and Barnes & Noble. It's available. You can get a direct link through my website. On my website, I have other things about other injuries, some other papers I've written about things that might be of interest to some people around medicine and some of the other projects I've been working on that might be of interest to people who are interested in those things. But I also have a second book called I've Fallen and I Can Get Up. Go back to the balance thing. So the second book is really about fall risks and how to prevent falls. So that also might be a value for some people as well.
Okay, cool. You can go to 40plusfitnesspodcast.com/615, and I'll be sure to have the links there. Dr. Reznik, thank you for being a part of 40 Plus Fitness.
Oh, thank you so much. This has been great.
Welcome back, Raz.
Hey, Alan. That was a really interesting discussion. You know, in the runner's world here, we talk a lot about knees, and it's not because running ruins them. I'm just going to tell you that right now. It's just a common injury. And so a book like this could be very helpful for some of us.
Yeah, he focuses a lot on pediatrics and sports injuries. And so there's a lot of that in there. So if you're a parent with a kid that's playing sports and things like that, there's a lot of information. Of course, this being 40 Plus Fitness, I didn't want to go down that line. That's not our thing. Although you may be a parent. So again, some things in there that can help, particularly if your kids are suffering from some injuries from the sports that they're playing. But he had part 2 and part 3 where he got into the knees and the shoulders. And so that's where I wanted to go, because I hear a lot of I can'ts because of, this problem. I can't walk or run because of my knees. I can't lift weights because of my shoulder. And it's true to a point.
Right.
Okay. Yes, you should probably not be running if you're having some difficulties with your knees. But if you're having difficulties with your shoulders, you probably can run.
Yes.
If you're having problems with your shoulder, you probably shouldn't be doing many upper body lifts. But you still got those legs. So you can do some stuff. So it's the whole concept of, and if your knee's hurting, maybe you can't do a whole lot with running and walking or whatever, but you could maybe get on a stationary bike, and that wouldn't put a lot of pressure on your knee. Maybe you go and start working on other parts of your fitness. So you're working on your mobility and your balance and things like that. Upper body strength. I don't know anybody who tells me I'm as strong in my upper body as I ever want to be. Most people say, I struggle with push-ups. I struggle with this. I'm not so strong here. So, these injuries or problems are not necessarily the right excuse to say, I can't.
Well, again, first of all, you need a diagnosis, right? You need to go see your doctor or your PT or somebody. But like Dr. Reznik was talking about, a patient who had, what was it? I think it was a hip fracture, but he was so sure that it was presenting in his knee, that it was a knee problem. And, as a trainer, you and I both have seen people that have a knee problem, but there's a kinetic chain issue. There's something, weak calves, strong quads and weak hamstrings, or, something else is going on that is presenting itself as a pain. But that's why you get a diagnosis, and that's why you get, the proper instruction on how to correct the issue.
Yeah, I couldn't help but think, okay, and so this is going to go way back, because we used to play tackle football as kids, and we played on this playground, elementary playground that had tetherball poles. Okay. So these are just poles. They're spaced out probably about 15 yards apart. Those were our first down markers, so it was just really cool to have all these tetherball poles along the sideline, until it wasn't. And so our friend was going out there, and he was trying to make a tackle on a guy who was trying to make it past the pole. He did, but our friend Timmy did not. So Timmy hit his face and his knee against the pole.
Oh, geez.
And so Timmy's laying on the ground, grasping his knee, yelling, my knee, my knee. And we're looking at him, your face.
Oh, no.
So pain is a weird thing. He needed 9 stitches to his face from that contact, not a single stitch to his knee. But so pain is a weird thing. And where we feel it and how we feel it is a unique experience. We've talked about pain a little bit on this podcast, but you can't trust how you feel pain to diagnose what's going on, particularly in complex areas of your body.
Well, yeah,
and
especially
pain, the knees, the shoulders, the ankles. all of it. You could be sitting there saying my ankles are killing me, and it could literally be your knees that are out of line. It could be your hips. It could be anything. You're just And so I would not trust pain to self-diagnose.
Oh yes,
an issue. Have a conversation with a professional. I'm not that professional. You come to me and say my ankle hurts. I'm like, go see a PT. Or if you feel like it's more important than that or bigger than that, go see an orthopedic guy. They're or a foot guy, because again, you can even specialize down. There are people who do knees. There are people who do shoulders. There are people who do feet, ankles. Find the right doctor to get the right diagnosis, and then do what they need you to do. So but this book was really good because, well, one, it had the big section on kids, but then the knee section and the shoulder section were really, really good. Probably not something that you would just want to sit down and read, unless you have an interest in the joint, which is once you hurt yourself, you start having an interest in a joint. Let me just tell you. So if something happens and okay, I've got this appointment with my orthopedic surgeon to talk about my shoulder, then this is a good book to kind of pull out and say, okay, let's look at the shoulder joint. Oh, okay. So this is how the joint works. This is the four muscles. And this is the way that all this is set up. And these are common problems. And then when the doctor starts talking to you about, well, it looks like you have a tear, let's do an x-ray. And then they come back later and say, okay, we're looking at your movement pattern and everything. We think it's a tear. We're going to send you to PT. Is that the right thing?
Sure.
Okay. And for most of us, we wouldn't know. So go to the PT. The PT will know. He'll do the PT. And if you don't start getting better, he's like, no, it must be worse than we thought. You need to go in for an MRI, and your surgeon will take you from there. Yeah. You go back to the surgeon's like, let's do an MRI. And you get the MRI and they're like, oh yeah, it's tore. So we need to repair that tear before you're going to get the benefits. That's just, that's how they work. And you're not going to know that when you first start this, unless you have a lot of experience with anatomy. If you do, then you may know, okay, no, this is not a little thing. This is a big thing. Like some people will see their bicep roll up in their arm when they tear a bicep. They'll see the same thing with their pec. They'll see the same thing with their Achilles. It rolls up like, what is the window thing? The window shades. It will roll up like that. And you will know, right away that you did something terrible to yourself. But for the most part, if it's just a little pain or pain within a certain range of movement, you may never notice it, or it may be just so little. We talked about frozen shoulder, and it's literally it hurts a little on this end, so I just don't do what hurts, and then a little bit on that end, and I just don't do what hurts, and it gets tighter and tighter a range over time to a point where you realize, I can't even scratch the top of my head, because I can't lift my arm. That's awful. when you're going to notice, and you're going to go into the doctor, and the doctor's like, well, this might heal itself or it might not. And true, what they're saying is absolutely true. But you can read a book like this and understand why they're saying what they're saying. Okay.
That's super helpful.
And that's where this all comes in. It's really hard to sit in front of a doctor and have them explain this stuff, because they went to medical school and they can pronounce all these words and all these medications and all stuff, because it's a particular vernacular that they learned in school of how this stuff does. Posterior means something, anterior means something, this means something, that means something. And so to them, it's a language, and most of us don't speak that language. So when they're talking, it's going to sound like a bastardized version of English, where they're just throwing in a bunch of maybe Latin words or something, and it's not going to make a lot of sense. But if you've got a book like this and you kind of went through it and said, okay, I understand there's four muscles here. When he says that muscle name, I say it in my book, that's this front one. And that's where I felt it. And that's why I can't do, a lateral movement or a lift movement with my arm, or a push away. You'll understand why you can't do, or why it hurts to do the things you're doing. It'll start to make sense.
Yeah. I feel like if you've had an injury in your shoulder or your knee, mine is an ankle injury, but I pay more attention to what I can and can't do. I pay attention to what my doctor tells me. I've been there with the cortisone shots. I've been there with the braces and whatnot. And, right now I'm healthy, knock on wood, but, a book like this would be helpful if your injury was progressing or becoming, like maybe you need some sort of surgery or replacement or something like that. So it seems like a very interesting book.
Yeah. And I totally agree with him. If you're taking one of these supplements, and you've been taking it for years because, this is good for me. Just stop taking it you just stop, just say, okay, I'm going to stop taking this and I'm just going to see how I feel. And by all means, if the aches and pains start coming back, then get back on it.
Yeah, for sure.
It's working one way or another.
Yeah.
I'm just going to say that. It's working one way or another.
Yeah.
And we'll have another conversation with a doctor in a couple of weeks that we'll get a little deeper into that topic. But
cool.
Yeah. So just recognize that, these things that are out there to help you, they should be temporary. There's zero reason for you to need a knee brace for the rest of your life.
Right. Yeah,
okay.
For sure.
If the doctor or a physical therapist fitted you with it and said, okay, I'm going to need you to wear this for the rest of your life, then that's a little different. But if you just went into the CVS and bought a brace and say, my knee feels a little better when I'm wearing this brace, you're not solving the underlying problem.
Yeah.
And in fact, you might be making it worse and not know it. So, again, I'm not a huge fan of self-medication. Obviously, if something's working, it's working, but understand why it's working, understand what you're doing. And if you don't know, yes, you can experiment on yourself, but, again, you might not be making yourself better. And right now you have the muscle around the joint to support it and do what you're doing. 20 years from now, you may not.
Yeah. Well, I always default. I'm not a doctor, so I rely on doctors and smart people like PTs to get me back in shape.
I swear by PTs, they've done the work, they understand. But you have to advocate for your own care. So when you go in, if they say, like doc, my shoulder hurts, and he says, well, no, it's your ankle. I'm like, okay,
wait a minute.
Now we got to have a conversation because that's not what I expected. Same thing with the guy who came in and thought, okay, my hip problem, they're saying it's a hip problem. I know it's my knee. At some point you have to open your brain and say, okay, explain to me, like I'm a third grader, why you think this is my hip, and then be open to listen.
Yeah, for sure.
Because there is some math there. It's kinetic chain. There is some reason why that might happen. And you just have to be open to it, not obliviously open, like, oh, the doctor said this, therefore that.
Right.
It's okay. Doctor just told me that he's going to have to do a complete knee reconstruction. I'm like, why? And he's like, well, there's damage there. I'm like, I can still walk. I can still do things. We won the kickball tournament this weekend.
Yeah.
Why would you need to do that? And sometimes, we just need an answer, or we need to make our own decision, get a second opinion.
Yeah, for sure.
So again, these are very complex joints. And that's why I really wanted to get into it, because it does hold people back from improving their fitness, because it gives them a constraint.
Yeah.
And constraints make it easier to say no. So if you want to get past the constraint, you need to understand the constraint and get past it with the help potentially of a PT and an orthopedic surgeon. Yeah.
Yeah, absolutely. I'd love to see more people out there walking and running. It'd be great.
Yeah, absolutely.
It's good for your knees.
It can be. With good form. Running has a form, just like every other exercise. So these things can be great for you. But again, you have to know your body. You have to know the form. You have to perform. So when you get fatigued, a lot of people lose form. So it's just, know your limits, push yourself out of your comfort zone, and then
Mhm.
you'll reap the benefit.
Yep. Sounds awesome.
All right. Well, I'll talk to you next week.
Take care, Alan.
You too.
Bye-bye.
Bye. Next time on the 40 Plus Fitness podcast, we meet Dr. Ellen Langer and discuss her book, The Mindful Body, Thinking Our Way to Chronic Health. Until then, have a happy and healthy week.